Welcome to Advocacy of the 49th Parallel. This session is on behalf of CAPS and APSA advocacy committees. The objectives of the session, so our goal is to provide a brief overview of the Canadian and U.S. healthcare system, with particularly focus on pediatric surgical care delivery models and identifying key advocacy and successes and challenges in each country. And we would be highlighting one example from each country on how pediatric surgeons have done advocacy and influenced policy. And we also hope to provide you some practical tools and frameworks to carry out advocacy efforts. So firstly, just providing a brief comparison of US and Canadian healthcare system. So Canada has a universal healthcare model. You guys might be already aware of that. It's a single payer publicly funded healthcare system. Medicare in Canada refers to the publicly funded healthcare system. It's funded through general taxation administered by individual provinces and territories. Healthcare delivery in Canada is decentralized with some variability across provinces. Healthcare in Canada is guided by Canadian Healthcare Act with 5 core pillars of Canada Health Act, which are public administration, comprehensiveness, universality, and portability and accessibility. Pediatric surgery in Canada is delivered via academic children's hospitals, which are concentrated in urban hubs, as you can see on the map. There are 15 Canadian children's hospitals, and hospitals are referral centers for tertiary and quaternary surgery. Of note, cardiac and solid organ transplant is regionalized in Eastern and Western Canada. The key advocacy priorities in Canada are wait time reduction by increasing capacity expansion and providing equitable surgical access in rural and remote communities, injury prevention, as well as focusing on health disparities and improving immigrant health and Indigenous health. And lastly, Canada lags behind in terms of the prioritization of children's health, responding to the recent 2020 OECD data, which demonstrated that Canada has declined in terms of pediatric outcomes compared to the OECD nations. And then next, Dr. Jose will be providing a brief overview of American healthcare system.
Good morning. So I'm going to be doing a very quick overview of the American healthcare system. And the good thing is, like the Canadian system, we do provide healthcare delivery. It's decentralized, but it's variable across the states. However, it is not a universal healthcare model. It is a multi-payer system. The term Medicare actually refers to only federally funded healthcare provided to those over the age of 65, and funding is provided by both federal, state taxes, and employers and private individuals. And so the interesting thing is that healthcare in the United States is actually tied to your economic status as well as your employment status. If you don't have health insurance, you're paying out of pocket, which really can bankrupt a lot of individuals. In terms of expanding healthcare through entitlement programs in the United States, there were 3 major acts by Congress. First, in 1965, with the Social Security amendments of Title 19, they established Medicare, which provided healthcare for those over the age of 65. You also had the Medicaid Act, which is actually a federally funded but state-administered program, which provides healthcare for individuals at below the 64% of the poverty line, as well as those with disabilities. This was expanded in 1997 for the Children's Health Program, which it's expanded eligibility for children and pregnant women. And finally, in 2010, the Affordable Care Act further expanded Medicaid to cover for individuals with a salary above 133% of the salary federal poverty line. Now, just like in Canada, healthcare is provided both in children's hospitals, but also in the community health center, covering about 470 children's hospitals. Specialized services are concentrated in urban areas, but you can see by this heat map here that actually the concentration are in urban areas, and in rural areas really do not have pediatric surgical coverage, for example, the state of South Dakota. So as a result, in the United States, a lot of the advocacy priorities, they focus both on healthcare finances, as you can see by the complexity of the system, surgical access in rural communities, injury prevention, and as we've seen over this meeting, firearm violence prevention, workforce and pediatric resource planning. So for our next speaker, we have Dr. Mercedes Pilkington, who is an attending physician surgeon at the Hospital for Sick Kids in Toronto, Canada.
Great, thank you. So we wanted to take a chance today to sort of talk through a couple of examples of advocacy campaigns that really have been spearheaded or at least partnered with pediatric surgeons in the past. And so on behalf of the Canadian Advocacy Committee, I'll be talking about some of the work that was done around all-terrain vehicles. And then next you'll hear from the American Advocacy Committee about button batteries. So all-terrain vehicles, or ATVs, we know that they account for about 100 deaths per year in Canada and 500 in the United States. And over a third, so 35 to 40% of those injuries do occur in children and largely adolescents, so under 16. And so pediatric surgeons have really been a part of responding to this as part of our injury prevention strategy in really thinking about how can we help reduce injury and death in children related to ATV injury. And much like we take a multimodal approach to pain management, to management of our patient, I think we can really think about advocacy in this sphere in a similar fashion. And so when we think about all-terrain vehicles and the injuries that can result from them, there's really a number of avenues in which there can be efforts towards advocacy, some of which are more closely linked to our common healthcare outcomes, but I think all are important to think about when we're really evaluating how can we help to advocate for our patients. So when we think about something like all-terrain vehicles, there's really the 4 E's that we think about. So the environment, how can we impact the environment that children and teens find themselves in that may impact their likelihood of injury? And that relates to some of the on-road versus off-road legislation in which work has been done. Enforcement is also incredibly important. We need some level of enforcement of the regulations that are being proposed. And things like age limits and helmet use have been really key around all-terrain vehicle use. It's also important to think back to the engineering and how can we partner with industry to find ways to make the ATVs safer so that people can use them for their daily activities, for their leisure, and do so safely. And then it's also really important to think about equity. So in Canada, we know that many of our remote populations may use ATVs for very practical daily purposes. And so we want to ensure that we're engaging them in this work and not just telling them you can't use them, this isn't safe, and really finding a way that works with the community to make it as safe as possible. And so I'm going to tell you a little bit about the story of Nova Scotia, because this was really a piece of the ATV work that pediatric surgeons, I think, have really helped to lead in Canada. So this was published back in 2004. The IWK is the major referral hospital in Nova Scotia. And for our American visitors, that's on the East Coast. And this is one of the big tertiary referral hospitals. And they have about 400 admissions a year for traumatic injuries. And they started to realize that they were seeing an increasing rate of children coming in with serious injuries. And you can see they're not just children seen in the emergency department, but these are children being admitted with injuries from all-terrain vehicles. And you can see it hit an all-time high of 18 patients in 2001. And I think pediatric surgeons did what we like to do. They took a look at that data. And I think what this story hopefully will show you is that they went beyond just publishing this data in a journal, which was the first step, and really started partnering with government and non-governmental organizations to do something about this. So Dr. Yanchar was the pediatric surgeon in Nova Scotia. We asked her to come present this today, but unfortunately she's retiring in just 1 more month. So she said she was on duty this week, so wasn't able to join us. But really, she was the pediatric surgeon who was invited to join this task force that was created after looking at this data, recognizing this was a problem within the province. She, along with many other representatives, including from the government, but also really strong strong community representation, formed this voluntary task force that reported back to the province of Nova Scotia. And really, this was focusing on the legislation aspect. And I think in what is really a success story, there were amendments made to the Off-Road Act related to the safe use of ATVs that next year, so in 2003. And in fact, there was a ban for children under the age of 14 for using all-terrain vehicles, aside from on closed courses. And what's actually interesting to note is that at that time, there were no closed courses. And so this was proposed alongside a plan to create these safe environments to use all-terrain vehicles. But none of these ever actually came to pass. And so if the legislation were being followed by the letter of the law, there was actually an all-over ban for the use of ATVs for under 14. And this got a lot of attention at the time. The Canadian Pediatric Society joined the pediatric surgeons in really advocating to say this is an unsafe tool or toy for children, and we really need to think about how it's being used. Dr. Yantra at the time similarly really wrote a plea to pediatric surgeons to consider this and to remember our role not only in treating injury, but in injury prevention. And I think if you look at the data here, you can see what looks like a really great success story. So 2003, 2004 is when the legislation was introduced. And you can see not only did ATV sales plummet in the province of Nova Scotia, but also hospitalizations, trauma visits, trauma hospitalizations. We saw a very real impact in terms of ATVs were becoming safer in the province. This was widely publicized at the time. This was in the news. This was in the media at the time because it was controversial. Not everyone agreed that ATVs should be taken away from children, but this was really getting a lot of attention. As you can imagine, industry also had something to say about us placing regulations on who can buy and who can use these all-terrain vehicles. Unfortunately, as great as this data looks and as promising as this sounds, I wish we could stop here and say that legislation is really the key and that needs to be our primary focus. But unfortunately, I've cut off the graph and it's not the entire story. So we actually see over the next 5 years, despite impressive improvement in those early years, everything came right back up to baseline by 2014. ATV sales climbed again, injuries, hospitalizations climbed again. And this is despite that same legislation being in place for the entirety of this time. So it has become clear that legislation alone is not sufficient. And so the authors, and I think we as pediatric surgeons, as injury prevention specialists, really have to think about what is the impact of legislation. It seems that there is some, but perhaps it really is that socialization around the time that also helps to create discussions around this, that brings it into the public sphere. At the time that this was happening, every time there was an ATV crash, it was in the news, it was in social media, and it was becoming more commonplace to understand that perhaps this was a risky behavior for teens. But with time, as industry realized that actually their sales weren't getting that bad, they didn't want the negative press, perhaps they backed away. As pediatric surgeons, perhaps we didn't realize that we needed to really maintain that same participation with media outlets to keep this in the front of the news, that we saw that unfortunately, despite consistent legislation, the attention to the issue and therefore some of the outcomes unfortunately started to wane off. And so, interestingly, just within this last year, a systematic review took a look at this to see whether or not legislation with regards to ATV use is sufficient and whether or not it's effective. And I think we can see really some mixed results here. So this, I think it gives us certainly some power to say that this is an important piece of what we do as advocates. We do need to partner with those who are able to effectively police the legislation around these to create regulations that are important. But perhaps it's not enough. We did see that some legislation around age-related restrictions or youth-directed safety measures can be helpful, but are insufficient. One area where I think we did see very good evidence is that helmet use does decrease traumatic brain injuries, which we know is one of the huge morbidities related to all-terrain vehicle. However, when you really piece down to the work that has been done, it becomes a little less clear what role the legislation plays in increasing the use of helmets. But absolutely, helmet use is an important part of this advocacy. And I think ultimately there was really limited data about how much those engineering-specific guidelines worked. So when ATVs were initially introduced back in 1972, there was a huge peak in mortality early on, and a lot of that was related to three-wheeled ATVs. And so we did see successful consent decree in which those three-wheel vehicles were really minimized on the roads. And so I think there were some great early successes there, but we perhaps haven't continued to see that same success through engineering. In terms of Canadian legislation, there's been a call to make this more standardized across the country, but you can see there's still some variability, particularly with regards to minimum operating age across the country, with it varying from a lower limit of 12 to 16. And really none of these are absolute bans. There's a lot of caveats and asterisks next to nearly every province. Finally, I think it needs to be said that this can't be done alone as either a pediatric surgeon, as a pediatric surgical society, even as a pediatric society. It does require partnering beyond our government organizations and consideration of non-governmental organizations. Parachute in Canada is one of our national charities dedicated to injury prevention, and they have been a really key player in helping to bring patient voices, family voices to the stories about ATV-related injuries, and have been an important partner to the pediatric surgeons who have done this work. So with that, I will turn it over to Dr. Berg, who's going to talk about an American example of advocacy initiatives for you all.
Yeah, good morning. So now I'm going to also discuss an example of a successful advocacy story from the United States. So pediatric surgeons also are very involved in injury prevention in the United States, and it was noted that button batteries were becoming a major issue for children and other small toys like magnets. The button batteries and other ingestions are a very common cause of emergency surgery, and the cost may be estimated as much as $1 trillion annually. It's more frequent that younger children from resource-limited families are impacted by button batteries and other small objects. The story really starts in the late 1960s, early 1970s, when there was an organization called the Consumer Federation of America. And it was the Consumer Federation of America that realized that there needed to be some type of regulation of the toys and other objects. And they lobbied for the Consumer Product Safety Act. So the story begins again in about 1972 with the passage of the Consumer Product Safety Act, which had 4 aims. And these were to protect the public against unreasonable risk, to assist consumers to compare products, to implement uniform safety standards and have consistent enforcement, and also to promote research into the causes of injuries and also how to prevent them. And so the Consumer Product Safety Act led to the formation of the Consumer Product Safety Commission. And this commission is an independent regulatory agency. It's composed of 5 commissioners, and the president appoints them, and then the Senate confirms them. And this commission is really critical to regulating products within the United States. The commission has the power to ban hazardous products, initiate recalls, and establish mandatory performance standards. At the time that the Consumer Product Safety Commission was created, the commission understood that they would need to be able to collect data in order to have solid information on which to recommend laws and regulations and where to put all their energy and resources to make the society safer. And so they created the National Electronic Injury Surveillance System, or the NEISS. The NEISS collects data from the emergency departments of 96 United States hospitals And so it's really just taking always a sample from these 96 hospitals that report to the CPSC. One of the toys or products which was noted to be becoming more and more of a source of serious injury were button batteries. And the NEISS noted that between 1992 and 2012, there were about 66,000 battery-related emergency visits. And so this became a product that caught the attention of the CPSC, and they realized that this needed to be more regulated to prevent injuries in children. By 2009, there was a child in the emergency department every 3 hours with a button battery ingestion. And this is a histogram graph from the NEISS that just shows over 2.5 decades that the incidence of button battery ingestions and also the incidence of major morbidity and fatal outcomes was just constantly increasing, to the point that the CPSC issued a major warning in the 1980s and again in the 90s against button batteries. And they also wanted to pass this button cell battery safety act. But things didn't really start to change until this article was published in Pediatrics in 2010. So there were two physicians. One is Chris Gitana, who's a pediatric ENT surgeon from the United States, and a pediatrician named Lidovisk, who published this paper in 2010, and they used the data from the NEISS, which showed there was a 7-fold increase of injuries between 1985 and 2009. And the article caught the attention of the CPSC, and Gitana and Lidovisk were invited to testify before Congress to try to help pass this Button Cell Battery Safety Act. However, despite testimony by physicians, the legislation failed to advance past the Senate subcommittee, and it essentially didn't go anywhere. It died. So this really galvanized Dr. Gitana and the other physicians, and the failure of the act to pass and the disappointment led to the formation of the Button Battery Task Force in 2012. So the Button Battery Task Force is a collaborative group between physicians, industry, medicine, public health, and government agencies with the mission to reduce the incidence of button battery injuries in children. And they knew that a really multimodal approach was going to be needed to make this whole issue safer for children. So between 2012 and 2020, the Button Battery Task Force did publish updates on the state of button battery injuries in the United States every year. They published an update through the AAP, but things didn't really change until 2020. And here we have an example of where a patient story was really one of the most impactful things as far as advocacy for other children. So in 2020, there was a patient named Reese Hamsmith who was actually cared for by Dr. Gitana, and she had ingested a button battery. She was a toddler. She developed a tracheoesophageal fistula, and she was in hospital for 6 weeks, and actually eventually she died from complications of the battery-induced fistula. So her mother decided that she did not want any other child to go through what she had gone through, and that these button batteries needed to be safer. So she became very active on social media. She started a nonprofit called Reese's Purpose. She garnered 80,000 signatures on change.org. And because the Button Battery Task Force was still involved with the CPSC, Dr. Jatana recontacted them, and Reese's mom, Tricia Hamsmith, testified before Congress. So essentially what happened is they were able to resurrect the Button Battery Safety Act from 2012 and bring it back again in 2020, 2021 with the help of Reese's mother, and also two senators that one from each party, one Democrat, one Republican, were very aggressive as well in supporting the bill and advertising it and promoting it among the members that it should be passed. And so between 2020, when Reese passed away, in 2021, end of 2021, the Reese's Law, which is essentially the same original Button Cell Battery Safety Act, was finally passed into law and signed by President Biden. And essentially what it says is that within the United States, button battery manufacturers like Duracell and Energizer must package those batteries in a way that are very difficult for children to open them. So they require scissors to open, and they actually have to meet the same standard as packaging for poisons. So this is a much higher level of safety for kids. And also the law allows for regulation of batteries that are being brought into the country from outside ports. So when they're inspected, if they don't meet these regulations, then the batteries and the actual toys can be turned away, and they're not imported into the country. So as of just this spring, one of the commissioners from the Consumer Product Safety Commission published an update on the website for the CPSC explaining how Reese's Law has been very impactful with giving regulators and inspectors real teeth to prevent these toys from coming into the country. And she explains that really nicely on the CPSC website. One of the tools that I wanted to, or that we wanted to let our other pediatric surgeons know about is right on the CPSC website, there is this QR code called saferproducts.gov. And so if you see any product or toy that your patients have ingested and have had an injury, you can very easily report it to saferproducts.gov. And the CPSC keeps track of this and reviews and looks at injuries that are happening. They compile the data, and it does make an impact as far as where they put their efforts for regulation. One thing also to comment is that as far as going forward with where advocacy needs will be in the next couple of years, we just learned also in April that the National Electronic Injury Surveillance System, which, as I said, that is the database that the CPSC uses, that database is going to be defunded. Unfortunately, instead of us being able to use data for writing papers or promoting regulations, we're actually probably going to be focusing some of our advocacy efforts on actually just having a database. So that's our sort of a very recent update as far as where our advocacy committee will be focusing our efforts. So now I'll just hand it back to Preet to summarize everything.
So next, we wanted to just provide some practical tips on advocacy work, as well as some advocacy frameworks that can be used to guide clinical advocacy. So this is a very nice framework from UICC, and you're welcome to also check the website, UICC website. They do have a very detailed advocacy guide. So in summary, it lays out very nice kind of steps for doing advocacy work. The first step, as in any research project, is to identify what your goal is and your objectives. And then secondly, specifically for advocacy work, it's very important to determine what's going to guide the advocacy effort. So we've seen today examples of how we can use data to guide advocacy work. We could also use patient stories and lived experiences, which can sometimes be a very powerful mechanism of doing advocacy work, specifically when you're doing a public campaign. Stories can be very powerful. And then as part of the framework, it also outlines that's very important to understand the environment. And that includes mapping your political environment, knowing what political context you're working in, and then identifying your stakeholders. And then it's also very important to know who your target audience is while you're doing advocacy work, because the communication tools and the strategies that will be used depends on who your audience is. And then it's very essential that we continually monitor our advocacy efforts and the outcomes and shift our gears. This is another very helpful framework. So this is published by UBC. There is a very detailed 10-pager advocacy guide and advocacy framework, and it essentially provides a very comprehensive overview. It divides advocacy over 2 axes. So advocacy can be seen as 2 different approaches. So a clinician can advocate with patients, where you collaborate with your patient and local community to identify advocacy needs, versus you can do more directed advocacy, whereas you as clinician use your professional expertise to guide advocacy efforts. And then there are, 2 kind of other axes that can be used to do advocacy work. So as a clinician, you can work as a health advocate agent, where you help your patients and communities navigate resources, for example, or you can do health advocacy as an activist, which involves raising awareness, doing public campaigns, and driving institutional and policy level change. And then I wanted to highlight again that political context is very essential, because there are certain policy windows that arise, which either can be a deterrent to advocacy work or can lead to success in advocacy efforts. So it's very essential to know political context. And if anyone's interested in reading more about the political context and policy windows, there's a very nice paper published in Lancet by Schiffman and Smith. And this is a very kind of nice table that highlights, knowing your political framework and who the actors and the stakeholders are, and how do we really establish which advocacy efforts need more priority. So if anyone's interested, can look up the paper in Lancet. And as Dr. Berg had just mentioned, that NISSS is now losing funding, and again, it just kind of shows importance of knowing political context and revising your advocacy efforts. And so right now, even as part of the APSA and CAPS committees, we're constantly shifting gears, evaluating our advocacy efforts. And as Dr. Berg had mentioned, now we're focusing on making sure we have our databases, we do not lose funding, so that we can continue our advocacy efforts. And lastly, there are various advocacy tools that can be used to communicate to different stakeholders. And I guess this graphic here provides like a summary. So depending on who you're communicating with, you can use different tools. If you're communicating with experts, you could use a policy paper. You can write, you can publish a peer-reviewed article, or if you're communicating with general public and you want to do more kind of activism work, you could do media op-eds, media interviews. So the various avenues to pursue advocacy work. And again, given the limitation of time, we only did a brief review, but there are lots of resources if anyone's interested in pursuing advocacy work. On APSA website, we have an advocacy page, and on AAP as well website, there is a advocacy guide, as well as on the ACS website, there is a very comprehensive advocacy toolkit as well. Okay, and any questions? And we wanted to also open up for any discussion. I know in the audience, there are a lot of people who've done advocacy work. So we're open to any questions or discussion.
So one of the purposes of this workshop was to see if we could start to brainstorm or come up with ideas for something in terms of advocacy that we can really combine forces between both the Canadian committees as well as the American committees. And we figured we'd have a captive audience of people who are actually interested in advocacy. We're just interested to see what is the temperature out there and what are some issues that you feel are really pressing at this time. Or is everyone still recovering from last night? Because I certainly am.
Thank you all so much. Sharif Emil here in Montreal, but I've split my professional time now almost exactly 50-50 between Southern California and Montreal. So I really got to get a bit of a perspective on what the different issues is. And when I moved here, I thought, okay, we're in a single payer health system. There's not going to be any major need really to push for pay. And that's just not true. Mind you, just having said that, I do think we have a lot less restrictions here in taking care of children. But I think the perspective is not everybody is necessarily going to get involved in a national effort or even a provincial or a statewide effort. I think most of the advocacy we do is what we do on a day-to-day basis. In Southern California, the biggest reason for advocacy was just to get kids the care they needed. I mean, one family and one child at a time. One of the examples was I would take care of a NICU child, and they would receive superb care. But the minute they graduate from the NICU, they end up in a Medicaid HMO. They're sent to a surgeon 2 hours away who's contracted with the HMO. I can't see them anymore. The surgeon who sees them has not operated on them. I mean, I'm sure Joanne is very familiar with these types of stories, and you who've trained or practiced in the US, this happens all the time. And I think this is where we really have to sometimes kind of shame people into doing the right things. And here on this side of the border, we don't have that problem. Any patient can go anywhere, which is wonderful. The word authorization does not exist in the Canadian context, which is, something that's always shocked me because Americans do not like anybody to authorize anything they do, and yet they're fine with insurance companies having to authorize everything they do. But we do have other issues here. We do have issues of resource restriction. Later this morning, we're going to be talking about what happens with our Indigenous patients, which is a really, really big challenge to provide them the care they need. We have issues of waiting lists. We have issues of constant triage where we're having to decide which child goes ahead of who because of limitations in OR resources. So I just wanted to offer the perspective that many people may not get involved in large efforts, but I think all of us are advocating in one way or another, one child at a time, one family at a time. And, I do a lot of work in Africa, as you know, and sometimes when I come back, people have a bit of a cynicism and say, well, I've taken care of like 30 children, and does that really matter? And I'm saying, well, it doesn't really matter. I do exactly what I do here. I mean, it's really not that different. Just take care of one child at a time, one family at a time, and advocate for that family in front of you. That's the responsibility you have at that point. And when you're dealing with that, all these other large issues are a bit outside that context. So anyway, I just wanted to offer that perspective.
Thank you, that's great.
Well, I gave other people time to get on the soapbox. Thank you. A couple years ago, there was a business meeting where it was very clear that a percentage of our membership doesn't believe advocacy belongs in APSA. I think the new president disagrees with that. I don't know how much we can say. Ken's sitting over there. She is very passionate about our role in advocacy for the next 12 months. And the committee talked yesterday about Medicaid. It's my guess that most of our colleagues at home have no idea how Medicaid works in their own state, federally, or even how to access Medicaid to make a plea for payment. It differs in every state, and I would urge everybody here to become educated if you're not, and then we are the advocates when we go home, and we got to make sure that all of our colleagues understand this very clearly. What does it mean if your state has a 20% cut in Medicaid funding this year? Everybody's going to get their appendix out still. Nobody's going to be dying in the streets from appendicitis, but there are going to be some really important changes, and there are some hospitals who may not survive that. And I think it's really important for us to be the people to spread that message.
Thank you.
guess I'll get on my soapbox too, Jared Howe, El Paso, Texas. Going along the Medicaid situation, about 80% of the population I take care of is Medicaid funded, so it's going to be a big issue. And so one of the things I deal with is, two corporate beasts in El Paso, HCA and Tenet, that have been very, very profitable and largely on Medicaid because they're able to make a lot of money off the NICUs and not actually reinvest in the community. So I think one thing that I'll definitely be doing, and I encourage everybody else to do, is these Medicaid cuts probably come, also push against these hospitals to, really look at what they're doing. And because we're basically subsidizing these massive corporate beasts with our tax revenue to pay for this care that is actually suboptimal. So maybe some good things will come out of this, and there'll actually be some consolidations of care and some common sense. So I'll just bring that perspective.
Thank you.
Ken Gao, Stony Brook. So I've had the opportunity to work with everyone on the committee, and advocacy is something that I and many other people in the room are passionate about. We always talk about advocacy and activism, and the question I would have for you all is, in the current political climate, at least in the United States, how will that affect your efforts to be advocates or activists? I'll also make a small announcement for everyone in the room that in attempts to try to save Medicaid, you will all hopefully receive something in the next 2-minute update, 2-minute turnover, to indicate how you can try to help maintain Medicaid in the United States. It is a fine line right now in Congress about whether Medicaid will be cut or partially cut. So we're going to hopefully give you tools in order to help with the efforts.
Thank you, Ken. Great. Well, I think that concludes our session. So thank you for coming. And if you wanted to